Okay, welcome back, everyone. What a wonderful presentation. It is my great pleasure now to introduce Dr. Katie Coe and Dr. Colin Burke, who will each be speaking about different phases in the lifespan and the intersection with homelessness. Dr. Coe is a psychiatrist both at Boston Healthcare for the Homeless and at Massachusetts General Hospital. And she's an assistant professor of psychiatry at Harvard Medical School. As I mentioned earlier, she graduated from the MGH McLean residency program, and she was the MGH chief resident and chief resident for community psychiatry. She worked closely with DMH and Boston Healthcare for the Homeless in that capacity, and that was really important in terms of her desire to pursue clinical work and research focused on underserved populations. So she's a member now of the street team at Boston Healthcare for the Homeless. She focuses clinical care on individuals who live on the street, and she uses a combination of street outreach and clinic sessions. And for those who are unstably housed, she makes home visits. She also has a general outpatient practice at MGH. She truly embodies a scientist practitioner model and has an incredible research focus on improving systems of mental health care for those who experience homelessness. I'm going to actually wait to introduce Colin until Katie finishes, if that's okay with you guys. But let me let you get started, Katie.
Good afternoon, everyone. Thank you so much, Dr. Cather, for that wonderful introduction. You have been such a phenomenal role model and leader in our Department of Psychiatry at Mass General for as long as I've known you. So I'm particularly honored to be invited to speak by you today. Thank you so much to Catherine and Paul for that fantastic and informative presentation, and to DMH, to the MGH CoE, to iSPARC, and to everyone who made this possible today. I'm honored to be presenting about homelessness across the lifespan, along with my wonderful colleague and friend, Dr. Colin Burke. And I will be focusing my part of the talk on my clinical and research efforts related to adult homelessness. And Dr. Burke will be talking about his pioneering efforts in clinical and research focused on youth homelessness. So I will share my slides. All right, great. Everyone can see that? Thumbs up. Great. Thank you so much. So by way of introduction, I just wanted to start by sharing a little bit about my personal journey to this work. So as a psychiatrist, whenever I hear talks like this, I'm always intrigued to understand why people do the things that they do. And I feel so deeply drawn to this work. I feel like it's almost a calling for me. And I've given a lot of thought to why it is that I feel so drawn to the work that I do. And the best answer I can give is that I grew up essentially in the opposite of homelessness. I grew up in Andover, Massachusetts, which is a lovely suburban town about 20 miles north of Boston. You can just see a picture of the town center in the upper left-hand corner. And I had essentially everything a child could want in life. I had a wonderful education, good health, two awesome older brothers, and most importantly, two extraordinary and loving parents. My parents were both busy professionals and yet found a way to be incredibly present and loving in my brothers and my life. And I think there's so many ways to be privileged in life, but I think a way that's not talked about enough is just having love and supportive role models in your life. And every day as a street psychiatrist, I see how much childhood trauma can ravage people's minds and lives until old age. And I feel so tremendously fortunate to have been born into the family I was born into. And I feel like for me, the home was really a place of safety and stability and refuge, as I wish it could be for every child in this world. So I just bring that up because in that context, I went off to college and homelessness wasn't really on my radar. It wasn't something I had thought about much. And for those of you who have been to Harvard Square, which is likely most of you, there's actually a surprising prevalence of homelessness in Harvard Square. And that observation of seeing people living in abject poverty in the shadows of quite literally the richest university in the world really irked me and also piqued my curiosity. And I still very distinctly remember the first time I ever talked to a homeless person. My friend and I were at an event, and we just on a whim decided we would give strawberries that were left over to a man who was sitting out front of beside the Harvard bookstore. And that conversation is really seared into my memory. I'm ashamed to admit it now, but I think I had these misconceptions that the person would be really difficult to connect with, or they'd be on a different wavelength. But it was a strikingly normal conversation. He talked to us about the Red Sox, the weather. He was grateful for the strawberries, and we went on our way. And that moment really shattered so many misconceptions I had about people experiencing homelessness. And I think it really made me realize that these individuals are just like me and just happen to have been born into a completely different set of circumstances in life. And had I not been so fortunate to be born into the family that I was born into, I could easily have been in their shoes. And I feel like to this day, that is a fundamental animating principle in my work. I really strive to give my patients the healthy and supportive relationships that my parents gave me, that they were denied through no fault of their own. So from there, I started getting more and more intrigued, and I went into medical school, knowing that I wanted to work with underserved populations, but not knowing I wanted to do psychiatry in particular. And I completely fell in love with the field. For those who are in the mental health field, I'm sure we can all relate that really at its core, it's about understanding the complexity and beauty of human beings. And what a privilege to wake up every day and do that as your profession. And so I was so fortunate to match into the MGH McLean psychiatry program, where Colin was one of my good friends and co-residents. And I feel so tremendously fortunate for my training at MGH McLean. I feel like it further deepened and inspired and nourished my interest in working with underserved populations, and particularly with homeless populations. The MGH McLean psychiatry program partners very closely with DMH. I worked at the Lindemann shelter during residency, which was a very formative experience. We partner very closely with Boston Healthcare for the Homeless program, doing street outreach. And also I worked at St. Francis House during my third year of rotation, which is a day shelter in downtown Boston. And these experiences, as well as the wonderful culture in the MGH McLean residency of just really valuing this work. Many of my other mentors and teachers are on this meeting right now, and just so grateful for the mentorship I received and for this work to be taken so seriously. And from there, I feel so fortunate 4 years ago to essentially have started my dream job working as a street psychiatrist at Boston Healthcare for the Homeless program in a joint appointment with Mass General, where I also have a general adult outpatient practice and do research focused on homelessness and mental illness. And this picture in the lower right-hand corner is just my wonderful street team colleagues at our holiday dinner a few years ago. I just feel so thankful to be able to do work that's challenging, but also couldn't imagine anything else I'd rather be doing. And you can see I'm also holding a newborn baby at the time, and my daughter now is 4. I have another little one who's 2. So this picture also marks to me the passage of time. So I'm sure many of you have heard about Boston Healthcare for the Homeless program, but just as a quick overview, it is a tremendous organization. As mentioned, works very closely in partnership with Mass General and with DMH, which I greatly benefited from in residency and further solidified my desire to do this work for a career. It provides care to 11,000 homeless individuals in 45 different clinical sites throughout Boston, including street and shelter-based clinics. So really the model of BHCHP and the idea behind it is to proactively bring care to people who likely wouldn't be receiving it otherwise. So because so many people who have experienced homelessness or experiencing homelessness have undergone trauma in their life, understandably, they're hesitant to trust in many cases, have difficulty engaging with traditional medical services, have had negative experiences with the healthcare system. So it's really on us to make the care as appealing and attractive as possible for this population. And that's why the shelter-based clinics embedded in shelters are so effective, and street outreach, which is the work that I do that I'm excited to share more with you about, can be such an effective model of care. And we really prioritize and value offering team-based care that's interdisciplinary, because a key lesson I learned in residency that it's not just about giving homeless people care, but also the quality of care matters. And we should be striving for as high quality care as possible. That care on the street is going to look different than it would, in the emergency room or inpatient psychiatric units, but we should still be striving to give the best care possible. And I truly believe this interdisciplinary team-based care is critical to that model. Studies suggest that oftentimes mental health is not the first priority for people experiencing homelessness. Understandably, oftentimes they're focusing on meeting basic needs, like food and shelter and clothing. So case management needs are often their first priority, followed by physical health needs, and then mental health needs based on the limited data that's available. But if I'm partnering with a case manager colleague who already has a pre-established relationship with a patient, they're much more likely to engage with me, to trust me if they already know Becky, my case manager colleague, or Rich, another one of my phenomenal colleagues. And using those connections to facilitate care is a key part of how our model works. So just to share a little bit more in depth about what this looks like on the ground, because the clinical work that I do is really where my heart is, and where I really believe so much of our effort should be focused in bringing these people into housing and the care that they deserve. So in the upper left-hand corner, you see Mike Jellison, our phenomenal recovery coach, engaging with a patient in a tent encampment. So we go to encampments, under bridges, sidewalks, and we really try and just meet people where they are, build trust, build relationships, and then hope that over time they'll get to a place where they trust us enough to engage clinically. Sometimes this can take days, sometimes this can take years. Eileen Riley, one of my mentors in this work, has this beautiful quote, and she says she'll meet a person, they'll be declining to engage in care, and she'll think to herself, okay, they're on the 5-year plan. And I just think that's such a beautiful and longitudinal perspective relative to, especially often how I was trained in residency, to make these kind of 20-minute assessments in the emergency room and figure out a person's whole diagnosis and life story. But so much of this work is about the longitudinal nature of the relationship and understanding people's hopes and dreams over time. So I feel that peer specialists are such a critical part of the model of street outreach and of homeless healthcare. Mike experienced 10 years of homelessness himself, as well as multiple substance use disorders and mental illnesses. And he is truly one of the most remarkable people I've ever met. He has completely rebuilt his life and has just this gift of connecting with people in a way that someone like myself, without that lived experience, never could to the same extent. And so I'm very excited to hear the peer specialist expert panel following Colin and I's talk, because I believe so deeply in this model of care in order to provide the high quality care we strive for. In the upper right-hand corner, you'll see Dr. Jim O'Connell. Many of you may know him. He's a legend in homeless healthcare and has a gift of seeing the individuality and light of each human being, and has taught me so much in this work. You can see he's sitting down eye to eye with one of our beloved patients. And this is something that we really try and do in providing care on the street is really get at, or ideally below, eye level with our patients, as a way to practice trauma-informed, non-hierarchical care. In the bottom left-hand corner, I'm with my wonderful case manager and nurse practitioner colleague. As I mentioned, we value this interdisciplinary model of care. So we're always going out arm in arm whenever we're doing street outreach or home visits. In our MGH-based street clinic, it's co-located care. So one-stop shopping, people can come and see myself, see our case manager, see our nurse practitioner. And it greatly facilitates care coordination, as opposed to my MGH adult practice where I see largely non-homeless patients. Sometimes I can put in a social work consult, and despite people's best efforts, it can take, a month for that patient to be seen or called. But, in this model of care, we can literally talk in the moment and coordinate care around patients, which is wonderful and I find so effective. You can see I'm holding socks. We use what we call engagement tools in order to help build that trust and alliance with folks. Unfortunately, because oftentimes people on the street don't often have an opportunity to take their socks off or take their shoes off at night, just a simple privilege that we often don't even think about having. But a lot of people on the street don't have that privilege. And as a result, they develop dermatologic conditions and infections. And so they really value things like socks and snacks and supplies, which we hand out as a way of building our relationships with folks on the street. And then finally, in the lower right-hand corner, my PA colleague giving a COVID vaccine on the street. And I think this is a powerful example of how effective medical care can be delivered on the street. We gave out over the past few years 850 COVID vaccines. Including booster shots as well. And I really believe had we not had those pre-existing relationships relationships with our patients on the street, we would not have had that much success. And so this is just kind of a constellation of some of the work that we do to give you an idea of what it looks like on the ground. So how have we as a society accepted this as normal? A man lying on concrete in the midst of homelessness and suffering, while a man in business clothes hurries by, seemingly on his way to work, anesthetized to the body of a fellow human being next to him. And I really believe that society and people are not at all ill-intentioned. People want to help, but this problem has become so overwhelming that people often just don't know what to do. They don't know what approach to take. And this has absolute real world consequences. The mortality rate in the homeless population is an abomination. Studies suggest that people who live on the street have a death rate that is 10 times that of the general population. And, you know, I knew the stats going into this work, but it's another thing to live it clinically. I hear about a death of my patient probably once every 2 weeks. We have about 40 patients a year. I just found out actually about an hour before this presentation about a 39-year-old patient that we just lost. And, you know, just for comparison, working in my MGH non-homeless clinic often provides useful comparisons. And I've been doing that work for over 4 years as well. And I've lost one patient during that time. And while that death was tragic too, every death is a tragedy in its own way. I think it just speaks to the remarkable disparities and injustice that this homeless population faces. And furthermore, the inequities continue into death. Oftentimes we don't have autopsies, we don't have funerals or memorial services or obituaries for this population. And so as clinicians, how do we better our care if we don't even know why the person died? It's so unsatisfying to not even have information clinically about what the person died from, because autopsies often aren't prioritized for this population. And so this motivated my colleagues and I to create a framework for how to help a person who's in medical need on the street. And this was published in 2021 in JAMA Internal Medicine. Essentially, it's a framework for how to think about a person on the street who seems like they may be in medical need. And we don't have time to go through this framework in depth, but the key takeaway is that there are decision points that you can make based on whether the person is awake or alert, depending on the weather, and whether they appear to be breathing or not. And I would say the key takeaway is before you continue walking past a person who's lying on the ground like this, or doesn't appear to be moving, just make sure that they're breathing at what appears to be a normal respiratory rate before moving on. For those who aren't trained in medicine, you still absolutely can help. A normal respiratory rate is generally thought to be about 12 to 18 breaths per minute. And if they seem like they're breathing more slowly than that, don't hesitate to call for help. If you are medically trained or trained in CPR, of course, if they seem to have a low respiratory rate, the next step would be to check the pulse. If they don't have a pulse, you want to start doing CPR. And if they do have a pulse, you want to think about giving Narcan. Narcan is now available over the counter. I believe that anyone ideally should carry Narcan if they can. It is an absolute life-saving treatment, and 90% of people who receive Narcan are alive a year later. It is an opioid reversal agent for people who overdose, and it can be easily administered. And I think this is a powerful way that we can save lives on the street and reduce suffering. And so this algorithm and framework that my colleagues and I developed is just an example of one of the reasons I love being a clinician researcher. Is it really allows me to use my clinical experiences, then to develop a systematized way to think about an approach that hopefully will help people and help patients going forward. So in terms of hope, I just wanted to share this powerful story of why I think street outreach can be so tremendously effective. So I don't know if anyone notices anything interesting about this picture. There's probably a number of interesting things we could pick out, but this is underneath the Zakim Bridge. I'll give you just a second to look at it. And if you zoom closer, I'm not sure if there's also anything more interesting here that anyone can pick out. It's hard to see. But there's actually a tent in this incredibly narrow pathway underneath the Zakim Bridge. So my very astute colleague was biking to work one day and had the perceptiveness to notice this tent. And so we started outreaching to this woman who was living under the Zakim Bridge. Turns out she had been living there for 8 years. And we outreached to her on a Monday, and she came into our street-based clinic at MGH on a Thursday, so 3 days later. And I just think that is remarkable. As I said, sometimes it can take years for people to come in, but she had the motivation and the interest and desire to better her life that she sought care just 3 days later. This woman is absolutely remarkable. She told me she has been in 150 foster homes throughout her life. Said there was a period during her childhood where she was just shepherded every week to a different foster home, and yet somehow still has this beautiful, positive spirit about her, was so motivated and engaged in her care. We started an antipsychotic, and she was housed within a few months, partnering with Pine Street Inn, and she has now been housed for the past year and a half. She's working 40 hours a week at a gas station, and she is engaged to be married, is sober, and wants to go back to school. And so that is an example of why I will never give up hope on anyone, why this model of care is absolutely needed, and we should never stop until everyone has this outcome. So transitioning into the latter half of my talk before I turn it over to Dr. Burke, I have been really struck at the same time how, despite there are success stories like that powerful one I just shared, and that should always be the example that we strive for, oftentimes the reality is not that simple, and the outcomes are not as glorious or wonderful as we would hope they would be. And so one of the things I've been most struck by is that when I first started doing this work, I used to think that the goal was to get my patients housed. Once they were housed, their outcomes had improved, they'd be thrilled, we'd be thrilled, and we move on to helping house the next patient. But oftentimes the reality is so much more nuanced and nonlinear and often ugly than that. And oftentimes I see people really struggle when moving into housing. Oftentimes people will end up sleeping back out on the street if they don't have the right support. Sometimes the power of community that actually is really powerful if you can see it up close. There's a tremendous community that forms on the street. But sometimes that power of community, if people are housed far away from where their companions are, that supersedes even having a roof over their head, and people can go from having these beautiful new apartments to sleeping back out on the street within a matter of weeks if they don't get the right support that they need. And we even lost people in housing from overdose very quickly after being housed. We had one person we housed on a Monday, and he died just a few days later, which is just such a tragedy. He finally gets the dignity and rest that he deserves, and then loses his life in housing. And there's actually some preliminary evidence that overdose does increase when people first move into housing, because they have this illusion of safety, but they actually don't have peers on the street, to give Narcan, to call 911. And so this finding has really piqued my curiosity and troubled me. And it really speaks to me the importance of two things. One, we absolutely need to do housing differently. I truly believe if housing is done correctly with the right support individualized for each person, then our outcomes will absolutely improve. But so often there's a homogenized approach that isn't tailored. And so I really believe that just like we have individualized psychiatric treatment plans, we also need individualized housing plans, for one. And two, it also speaks to me the critical importance of homelessness prevention. So often the trauma, the adversity, the suffering that these individuals have encountered that led them to the point of chronic homelessness can't just be undone simply by moving into housing. Housing itself is not a panacea without the right support. And so this has got me thinking about homelessness prevention. I really and firmly believe that if we're going to solve the problem of homelessness, we really need to take a more upstream approach and focus not just on housing those who are already homeless, which is so much of the public discourse and the research and clinical focus. While this is very important, I really think if we are truly to nip this problem in the bud once and for all, we absolutely have to focus on the pathway from childhood to homelessness and all the factors upstream that determine whether someone becomes homeless in the first place. And so the research suggests there's a variety of individual level determinants and community level determinants that predict likelihood of becoming homeless, and Dr. Brooke will talk more about this in his part of the presentation. And then there are also a number of high-risk transition points. There's a growing body of evidence around this. So children leaving foster care, people leaving jails and prisons, and soldiers leaving the Army are known to be 3 critically important high-risk transition points where people are at particularly high risk for becoming homeless. And so my research has focused especially on soldiers leaving the Army, and we sought to answer a key question about whether homelessness could be predicted with a high degree of accuracy in soldiers transitioning from the Army to civilian life. So to be able to prevent homelessness, we need to be able to predict it. But the problem is that there have been very few studies on homelessness prediction, and the ones that do exist have been limited by the ability to predict who is at highest risk with accuracy. And previous interventions, therefore, have been very universal, so targeting just a whole population rather than a specific targeted population, which is arguably an inefficient use of society's resources. So I was very fortunate to work with Dr. Ron Kessler and his team at Harvard Medical School to work on this very question. Can homelessness among U.S. veterans after leaving the Army be predicted with accuracy based on data collected during their time of military service? We used the database called Army STARS, which is a major neurobiologic epidemiologic study of risk and resilience in soldiers, and it had been used to predict a number of clinical outcomes, including suicide, but homelessness was a variable that was a part of that database, but had largely been untapped. And so we looked at homelessness as a self-report outcome, and we used information that had been collected about these individuals during their time of military service using a rich collection of data sources, including self-report survey data, administrative data from the Department of Defense, and also geospatial data based on the county that they anticipated moving upon leaving the Army. And we used machine learning methods to analyze the data. We had nearly 2,000 predictors in total and about 17,000 soldiers in our database. It was a very large study and prospective longitudinal study that followed people over time, which was a major strength of our study. Machine learning is a form of artificial intelligence that is able to analyze these large data sets. So our results show that a prediction model for homelessness can indeed accurately target soldiers for preventive interventions before transitioning to civilian life. The results show that those in the top 20% of predicted risk made up the majority of those who reported homelessness. So in other words, the majority of those who reported homelessness were in the top 20% of those predicted to become homeless. We interestingly found the nearly 2,000 potential predictors that indicators of mental health, and especially depression, a lifetime history of depression, a lifetime history of PTSD were the most important predictors, as well as certain lifetime traumas, like the trauma of having a loved one be murdered, and adverse life experiences, including childhood homelessness. And so these factors were found to be more significant predictors than things like Army career variables or geospatial variables in terms of where the person moved after leaving the Army. And so I feel like this further speaks to the point of how much adverse childhood experiences, trauma, and mental health can sow the seeds for a pathway to homelessness. And so what I think is most exciting about this research is that it has real world implications, just like Catherine and Paul's fantastic research showed. I really believe that research is best used to make an on-the-ground impact, to touch people's lives and move people towards better outcomes. And so we've been spending about the last year designing the next step of this, which is developing a preventive intervention for these high-risk soldiers now that we have the tools to be able to predict with accuracy. So it's a case management intervention that targets these people who are at particular risk and links them up with services and with the aim of preventing them from falling into homelessness and other adverse outcomes. And I'm happy to share that we actually just launched this pilot last month. It's going to be a 6-month intervention, and then we hope to evaluate and analyze it. And in conjunction with this, we're also pursuing qualitative interviews with people who left the Army and became homeless, who are now back housed, to get their input on what they think an ideal intervention would look like from their perspective. And we're just embarking on that study as well. And so just to review, so often we're used to seeing this unfortunate pathway. People go from childhood to homelessness. and back to housing and sometimes back to homelessness again. But the goal of this research and a lot of Dr. Burke's research as well, which he'll talk about, is to intervene, to identify risk factors, to intervene, to prevent people from becoming homeless in the first place and letting them move straight to housing from high-risk transition points and from childhood to be able to live a life that they desire and deserve. So thank you very much. And with that, I will turn it over to Dr. Colin Burke.
Thank you so much, Dr. Coe. That was beautiful. You just embody an incredible combination of being compassionate and pragmatic, and just a wonderful physician who's doing something very important and not overlooking these people that are so overlooked by many of us. So I love your work. Thank you. So I want to now introduce another fantastic science practitioner, Colin Burke. He is a psychiatrist as well at Massachusetts General Hospital and an instructor of psychiatry at Harvard Medical School. He's the medical director of the MGH Addiction Recovery Management Service, or ARMS, and he is the incoming director of the Youth Experiencing Homelessness program at Mass General. And in this position, he will head a new collaborative clinical and research program aimed at providing high quality psychiatric care and conducting innovative research on multidisciplinary treatment interventions for these youth in collaboration with Bridge Over Troubled Waters, Boston Healthcare for the Homeless, and our Center of Excellence at MGH. His research centers on the connections between psychosocial adversity, stress, resilience, psychiatric illness, and substance use among youth experiencing homelessness. And like Dr. Coe, he came through the MGH McLean residency program and was a leader and important figure in the community rotations. And he described many of these rotations as being very important and formative in terms of his career goals of working in community psychiatry as a clinician researcher, particularly working at St. Francis House, Nashua Street Jail, and Boston Healthcare for the Homeless. So it is a delight to have you present today, Colin. Thanks for being with us.
Thanks so much, Dr. Cather. I really appreciate that introduction. Thank you to Katie and to Cather and Paul and everyone today. It's really an honor to be able to present in this group and to be able to share a little bit of our work and the impact that the Center of Excellence has had on my work in the sense of community and collaboration in some of this work that we care so much about. So I'll share my slides here. Okay. So I'll be talking about the work that we've done, and specifically with transitional age youth experiencing homelessness. So youth within the ages of roughly 16 to 25 years. So like Katie, just wanted to share a little bit about kind of my pathway into this work. And especially, I think, just to give a little bit of context to how grateful I am to the Center of Excellence, having access to their incredible resources, mentorship, and support at this point in my career. So like Katie, I grew up in the Boston area. I've had a long-standing interest in the care and well-being of individuals experiencing homelessness, starting in high school and a formative year prior to medical school as an AmeriCorps case manager with the Boston Healthcare for the Homeless program. So like Katie, this is something that has been an interest of mine and kind of a driving passion for quite some time. And as Dr. Cather mentioned, really solidified in training at MGH and in some of the community psychiatry rotations at the Lindemann, at the Nashua Street Jail, and especially in a longitudinal clinic at St. Francis House in Boston. And so through training in adult psychiatry, child and adolescent psychiatry, addiction psychiatry, and the Mass General Brigham system, this is something that I've really cared deeply about, something that I've really kind of hoped to be able to continue as a clinical and research career. Been fortunate to have some research funding through Mass General, Harvard Medical School, and now a funded research project through the National Institutes of Health and the American Academy of Child and Adolescent Psychiatry. So I'm very grateful for those sources of funding for this research that I'll present. And then I want to just set the context that a lot of the work that I'll present on transitional age youth experiencing homelessness is deeply indebted, fully indebted to an academic community partnership that we've been able to create with Bridge Over Troubled Waters. So many people on this conference are probably familiar. So Bridge Over Troubled Waters is a very long-standing agency in the Boston area providing services to youth experiencing homelessness. A full range of services, everything from emergency drop-in services to support with psychological counseling, psychiatric treatment, medical care, educational resources, occupational, vocational support, transitional housing, rapid rehousing. I mean, it really just runs the gamut. And they've been in the Boston area since the 60s, a really well-known, trusted organization. And they've been just incredibly welcoming, incredibly collaborative research partners. And Dr. Cather and others in the Center of Excellence have ongoing research projects at Bridge as well. And this has been just a really fantastic partnership. We're so grateful for everything they've offered in terms of expertise and partnership. And it's just been a really wonderful collaboration. I also wanted to just early on, in case I run out of time, just my kind of nuclear team, just kind of shout out to, so Dr. Tim Willens, who's the Chief of Child and Adolescent Psychiatry at Mass General, has been an incredible supporter of this work from the very beginning, from a clinical and research perspective. Peter Ducharme, who's the Clinical Director at Bridge Over Troubled Waters. Sylvia Lani, who I think is on this call, our current Clinical Research Coordinator. Shay Furman, who was our prior Research Coordinator, who's currently a UMass medical student. We're incredibly proud. And then Maura De Salva, who's done a lot of work on the statistics that I'll present here. So I thought what I might do is just offer a broad overview of a few different areas of research that we're engaged in. Not because people are going to remember the specifics of each thing, but just to give a sense overall of kind of, I see each of our little projects to this point as a kind of foundational brick moving towards bigger studies that we're planning and very excited about, which I'll talk a bit about. So when we started out in this work, in this collaboration with Bridge Over Troubled Waters, as a psychiatrist, I had some really basic questions that I was hoping for easy answers to about kind of just getting the lay of the land with youth experiencing homelessness. So what are rates of common disorders in this group? Depression, anxiety, substance use disorders, neuropsychological dysfunction, many of the same things that Catherine and Paul talked about, right? You know, this is an adolescent, young adult population with many of the same struggles and challenges. And so, you know, asking the question, what are the rates of common disorders? How do they overlap with each other? What's the sort of, can we get a bit of a three-dimensional feel of the complexity and the lived experience of this group of youth? So in order to try to get at some of those questions, we conducted a systematic review of the literature, looking at rates of psychiatric conditions, substance use disorders, and neuropsychological dysfunction among youth experiencing homelessness in this transitional age group. And I'll put up here, these are just the sort of major outcome findings. So you'll see there's 3 columns here, just a list of common disorders. TAYEH is transitional age youth experiencing homelessness. And then we compared those to just general population mean from averages from this age group. So I think there's 3 major takeaways from these findings. The first is that the rates of these disorders are markedly high. It's really quite shocking. Compared to the population means, most of these disorders are twice, if not 3 or more times as common in youth experiencing homelessness. The second big takeaway, I think, is these are incredibly large ranges. So if you were to go up to someone and say, what's the rate of depression among youth experiencing homelessness? And they said, well, it's probably somewhere in the range of 30 to 95%. You probably wouldn't say, wow, you seem like a real expert in this area. And this is with all due respect to the incredible researchers and really dedicated, long-standing body of research investigating this population. I think it speaks to challenges in implementing really precise research methods with youth experiencing homelessness. And what we ended up finding was of the 32 studies in this review, only 4 of them used structured diagnostic tools based on the DSM, which is one lens of understanding and sort of categorizing disorders. The rest of them used short screeners, which can suggest disorder, but maybe not definitively, or ask youth, what have you been diagnosed with in the past? And for those of us who have worked with youth who have had complicated lives and long treatment histories, I mean, many of them can honestly say, if you ask them that question, well, everything, or I don't know, or it depends who you ask, So I think it just points to some of the logistical challenges that there are in implementing structured, rigorous diagnostic methods in this group of youth, but also the importance of doing that, right? Because the hope would be that we could get to a more precise understanding of what are the disorders, how do they overlap with each other. And I'll talk about the limitations of that as well. I think it's really important. And I think what Catherine and Paul brought up, I'm so glad they brought that point up about the risks of over medicalization and of using certain lenses. I think that's incredibly valuable. And at the same time, as a researcher and a clinician, there is some value in being able to say, can we agree upon a diagnosis to help drive a treatment plan from that one perspective? And then the third thing I'll bring up just as a point about this is it's a relatively short list of disorders here. The reason being that we only decided to include on this list studies that reported prevalence for more than one study reported prevalence for each of these disorders. So there was a longer list of disorders, which unfortunately only had one study which suggested a possible prevalence. But again, due to the lack of precision, it's hard to make sense of just one finding from a smaller sample. So much more research is needed and more precise research is needed to sort of replicate these findings and help hone our understandings. So I provided as context for our work because that meant that we kind of wanted to start at a very basic level. And so the first project that we undertook in partnership with Bridge Over Troubled Waters was trying to answer that very basic question. What are the rates of common psychiatric conditions and substance use disorder conditions? How do they overlap with each other? And how do we sort of start getting a view of the complexity and where we might be able to add some value with interventions? So this is the preliminary slide or poster that we presented at the Child and Adolescent Psychiatry meeting a couple of years ago. At this point, we had done a survey of 76 youth. For the full study, we ended up surveying 140 youth, but the rates remained relatively similar. So we had really broad inclusion criteria, just anyone accessing services at Bridge Over Troubled Waters. And we implemented a structured, kind of rigorous DSM-based diagnostic interview. And then got a range of other psychosocial survey data as well that we were interested in. So I think the headline findings here, you can see the rates of common disorders are markedly elevated again in this population. Specifically, the most common condition was cannabis use disorder. And that's not any cannabis use, that's disordered use, meaning there's some amount of functional impairment associated with that use. That was a really striking finding for us. And then other common child and adolescent psychiatry conditions, anxiety, OCD, depression, bipolar disorder, ADHD, post-traumatic stress disorder. I think one big takeaway from this is that if you look at these disorders and their relative frequencies, it's more or less identical to the national population of youth in this age category. The difference is that these rates are much higher, but the kind of shape of what, who has which diagnoses, what's most common is very similar, meaning that at least in this sample, this was not a categorically distinct group of youth with a different pattern of disorders or who looked so different from the national population. It's just that the rates of each disorder was much higher. And as you'll see on the top right here, the rates of overlapping diagnoses were much higher as well. So around 70% of these youth had more than one psychiatric diagnosis, and around 20% of them had this specific overlap of mood disorders, anxiety disorders, and cannabis use disorder, which is something we've taken a great interest in understanding that kind of picture as well. In terms of related psychosocial findings, and we have many more that we'll talk about, but one thing that was really striking and unfortunately probably not surprising is the rate of adverse childhood experiences. So 95% of these youth had at least one adverse childhood experience. The average is around 4 out of a total of 8 categories. From my reading of literature and sort of age-matched larger population studies, the number of youth in this age group with more than or one or more adverse childhood experiences is in larger samples is usually about 50 to 60%, and the average is about 2 out of 8 categories. So you can see these are just significant or much higher rates of these early life adversity experiences. So then we tried to get a little bit of a more detailed look at how these disorders overlap with each other. Again, not to over-rely on the medical model, and not to say that the DSM is the be-all and the end-all, because it is not, and that's probably a topic for another entire conference. But again, as one lens, right, if we're going to be clinicians, psychiatrists working with youth in these settings who are coming to us looking for treatment, I think we have an obligation to be as thoughtful as we can about psychiatric diagnoses and understanding the whole person, right, the bigger picture, in ways that we'll talk about, right? But I think that is one small but important area that helps drive treatment, and especially if we're going to start thinking about medication treatment or specialized therapies. So this is data from our full 140-person initial sample size. And you can see here again, reporting on just the rates of overall disorders. One thing that was not on that prior slide that I'll just highlight is rates of suicidality, prior suicide attempts. This is something that was shockingly high in this group, unfortunately, as well, this group of youth. I was just looking at the most recent data that I could find among high school students. Again, general population is about 9% of high school students will report a prior suicide attempt. Here we have 36% of these youth reporting a lifetime suicide attempt. As Katie mentioned, that youth in this age range have about a 10 times higher mortality rate than age-matched peers in a general population. And the leading cause of excess mortality in that group is overdose and suicide, unfortunately. So this is a really important outcome and something that we're really, really interested in looking at. What are the drivers of this risk? How can we understand it? And how can we help to sort of mitigate some of that risk? This is a complicated slide. I'll just point out. So what we have here is we pulled out cannabis use disorder and alcohol use disorder, which were the most common substance use disorders. The colors here are just increasing severity of substance use disorder. And so what we see on the left here is just the youth with the highest severity substance use disorders, that red bar, have the highest number of average additional psychiatric diagnoses. So youth with highest severity cannabis or alcohol use disorder, on average, have 3 or more additional psychiatric diagnoses. So just this kind of multiplying complexity of disorders. And then in each category of diagnosis, again, you can see as you go up in severity of substance use disorder, there's just increasing rates of each category of disorders. Speaking again to this kind of complicated nexus of high severity substance use, complicated overlapping psychiatric conditions. And again, this is something that's really of interest to us as psychiatrists as we think about designing interventions and prioritizing how we're going to be of most use in our work. So again, just to give a little bit of a snapshot, another area of research we've been very interested in, and the topic of my current NIH-funded research study, is looking at the rates of cannabis use disorder in this population. So, interestingly, I don't know, maybe someone, I'm interested in the Q&A, maybe someone has an idea, but like when I looked at that rate of cannabis use disorder, 44%, which is so much higher than other youth this age, it wasn't entirely intuitively clear to me why that was the case. And so in kind of talking with our colleagues at Bridge Over Troubled Waters, talking amongst ourselves, reviewing the literature, one hypothesis was that there's a really high burden of stress and dysregulated stress reactivity that these youth experience. So high burden of stress, I think probably people understand, right? Like this loading over a lifespan, even a short lifespan of adverse experiences and some things that we'll talk about specifically that lead to this kind of baseline high burden of stress. Stress reactivity then is when I have an acutely stressful experience, something that causes me fear, something that makes me maybe fear for my life or even just startles me. How active is that response? How quickly does it return to baseline? And then how quickly do I habituate to repeated stimulus? So some of the things that we thought might be driving this and the reasons that we came up with this hypothesis were, again, high rates of early life adversity. We know that youth in these groups have higher rates of discrimination and stigma based upon racial and ethnic factors, LGBTQ, sexual orientation, and gender as well. Homeless status itself as a cause of discrimination and stigma, and other, I'm sure many others that we could think about as well. We were curious about the role of resilience in this, and we'll talk a little bit more about how we define and think about resilience. And then the rates of psychiatric and substance use disorders. Again, there's literature in other populations showing that burden of psychiatric and substance use disorders causes elevated stress and dysregulated stress reactivity. So we decided to do something that's been interesting and a little bit atypical. So we've designed a study where we're meeting youth at Bridge Over Troubled Waters, doing a diagnostic survey and a number of other psychosocial surveys. And then we're walking with them to a lab at Mass General where we're doing assessments of psychophysiological parameters. So things like heart rate variability, skin conductance, blink response. And we're actually conducting a sort of safe and ethical and tested startle response paradigm where youth put on a set of headphones that plays a loud tone that causes a startle. And we can then measure what's how high is that response? How does it change over time when this is repeated at random intervals? And trying to just better understand some of the stress responsiveness and seeing how that relates to youth use of cannabis or other substances, other psychiatric conditions, and this whole range of other factors. Again, just trying to better understand in as many dimensions as we can the lived experience of these youth, and from a sort of medical model, from a sociological model, from an anthropological model, from a just humanistic model, like just being as curious as we can and gathering as much information as we can from all these different areas. I have an eye on the clock, so I want to wrap up so we can get to questions. I'll point out we have become very interested as well in the study of resilience. One of the things that's become very clear to us is that in thinking about resilience as related to potential negative outcomes in this group, like suicidality, thinking about internal resilience. So a person's own stress responsiveness, how I manage my stress, things like mindfulness and skills and attitudes, all very important, but equally important in this group is external resilience factors. So things like social connectedness, positive peer networks, mentorship, access to basic, food, housing, etc., spirituality and connectedness, if that's something that's important to them. So we've done some research, which I can talk about later. I won't take time now, but just highlighting the important role of those external resilience factors and really trying to broaden the scope of how do we think about resilience and resilience-based interventions in this group. And then I'll just say for next steps, we're very excited to be embarking on a combined clinical and research endeavor, partnering with Bridge Over Troubled Waters, collecting data on the responses to interventions and better understanding how all these factors lead to improved outcomes and how we can prevent against worsened outcomes. I'm happy to talk more about that as well, but I do want to wrap up and give folks time for questions and comments. Thank you so much.
Thank you so much, Colin. That was wonderful, absolutely wonderful. And it really reminds me of, great researchers who people, stand on the shoulders of, people like Paul Farmer, who, started out by looking at, in low resource settings, what's the epidemiology of disease? And if you don't understand that, you don't necessarily know what your starting point is or how to even think about the inequities. I'm waiting for people to put things in the Q&A. I could ask you a question first, which is, I wondered how intervening and starting to treat some of the underlying mental health conditions might, what were your observations or evidence shows about the impact on the substance use disorder? Are you tending to see some improvements once people receive treatment?
Yeah, I'm so glad you asked that. And I can say so there's a great deal of overlap actually with our work at Mass General and the ARMS program, so the treatment of youth young adults and adolescents with substance use disorders. And certainly the evidence would suggest that treatment of co-occurring disorders is an important part of recovery. Not that, these are really complicated cycles where psychiatric symptoms can drive substance use and vice versa. And sometimes it's just, there's this kind of complicated mix of things, but certainly treating psychiatric disorders, whether that's with medications, with therapy, again, being really creative and thoughtful about what these interventions look like. But that is going to be an important part of recovery, an overall kind of recovery-based plan for these youth. So absolutely a hugely important factor and component to the treatment plan.
And maybe this is a question that could be good for both Katie and Colin to sort of talk a little bit more about, is thinking about, someone made a comment that the value of internal resilience and external support is very important. And that youth without strong support systems and who experience early life stress experiences don't have the support system, or so are not taught resiliency skills. So there's this sort of feedback loop that's happening. Can you speak to some of the, maybe examples of resilience? Because what's notable in light of those extremely high rates of adverse childhood experiences, it's notable that not everyone has a mental health condition or a substance use disorder. So what are some of those resilience factors that are protecting people? And maybe Dr. Coe can also talk about that in terms of looking at people on the street and whether mental health conditions are perceived as ubiquitous, or do you see some people who do not have mental health conditions and are on the street for different reasons?
Yeah, I'll start by saying in some of our preliminary research looking at resilience factors, internal resilience factors, we actually did not find any relationship between psychiatric diagnoses, substance use disorders, other things that we might have thought might be related, and in resilience per se in this group. And that may be because of the high rates of psychiatric conditions we have, that so many of these youth are experiencing psychiatric conditions and substance use disorders. From a statistical standpoint, it may be hard to differentiate. But I think just the broader point is really important, because I think with all good intentions, we risk perpetuating stigma by putting so much of the emphasis on, internal resilience, skills-based work, mindfulness interventions, all of which are incredibly important. And I'm thoughtful about my colleagues from UMass. I know there's been so much pioneering work there, but I often say, if we could just sit in a group and have, each youth really taste the raisin, and that would be like the curative thing here, that would be fantastic, but I don't think that's it, right? It's not all internal. I think we risk perpetuating stigma and missing a whole range of external factors that should be thought of as incredibly important resilience factors, and really being thoughtful about building those out.
Yes, thank you so much, Colin. That was such a fantastic presentation, and I love the question, Dr. Cather. So I will just say, clinically, the sequela of trauma is probably the number one thing I treat. And I think that I'm so glad you brought that question up, because I think there's so many misconceptions about homelessness and mental illness. One of the foremost of which is that people just have schizophrenia, or schizophrenia is the most common mental illness on the street. There's actually epidemiologic data suggesting that of the mental illnesses studied, schizophrenia is actually the least most common. Isn't that fascinating? So Gutwinski et al., researcher from Germany, published a really excellent 2021 meta-analysis of 39 different studies in 11 different countries, found that the most common mental illness and substance use disorder was alcohol use disorder, followed by drug use disorders, and then personality disorders, which I actually see as trauma-based disorders. And then mood disorders, followed by psychotic disorders, particularly schizophrenia. And I think that really mirrors my clinical experience. Though psychotic disorders are still overrepresented, it was 12% in that study, which is still 12 times the general population, right? We know the universal prevalence is around 1%. I think it's a really important finding, because so much is the sequela of trauma, including substance use, which, as Dr. Burke's research also highlights, I think so oftentimes people use at least what I see as a way to kind of mitigate the pain and suffering that they've experienced, to kind of, deal with the trauma they've experienced. And then once they become homeless, it can be such a brutal and dehumanizing experience. Our recovery coach, Mike Jellison, says he used substance just to kind of survive the misery of the streets. just drinking made him be able to bear it in a way that he wouldn't have had he not turned to substances during that time. And so, the long-term effects of trauma include difficulty with regulating emotions and forming healthy relationships, having distress tolerance, and that's so much of what I treat. And at the same time, clinically, I'm just blown away by my patients' resilience in light of that, just in the sense of, wanting to move forward every day with their lives, to wake up every day and, seek care in some cases for patients just, who still somehow have it in them to be kind and to, see the best in people. It just blows my mind. So we need people like Colin to understand more where that exactly is coming from and what can foster that resilience. But I think in my experience clinically, what I've seen is it's just having somebody supportive in their life. Oftentimes there's tremendous parental trauma, but sometimes there's a grandparent or friend or just someone in their life that helps them get out of a really awful period, or if they're still in it, that's often what can help bring them out and foster that resilience.
Beautiful. And I think you really answered one of the questions here about the difference between stress versus mental illness. Let me ask you a question for Dr. Burke. I'm curious about the family context of transitional age youth experiencing homeless, no meaningful support available, potential supports which the youth is conflicted about. Is there a role for family engagement, or are the families best bypassed in helping the youth?
Yeah, it's a fantastic question. And I think the probably unsatisfying answer is that it's really context dependent. It depends on the individual. As Katie mentioned, a lot of pathways into homelessness for this population have to do with direct family conflict, whether that's interpersonal violence or stigma and being kicked out of the home related to a personal identity issue, or other factors, aging out of the foster care system. It's complicated, right? And so there's different pathways that may imply different levels of connection to family. I think one thing that's nearly universal is a disrupted sense of attachment, meaning that even for those existing relationships, it's often challenging to pull on them. It's challenging to sort of rely upon those relationships. As a child and adolescent psychiatrist, this is something we're always thinking about, always trying to foster, always trying to encourage when it's safe and when it's possible, but also being thoughtful about, this young adult population. It's very interesting from a developmental standpoint, which we could talk about for another hour, the desire for autonomy, the desire for independence, and how do you balance that with helping to foster those family relationships if they do exist, or important mentorship relationships. So it's a complicated topic, but absolutely, I think, we're always looking for ways to create and foster those types of relationships and help to build them as we can when it's safe.
I just want to give voice to an excellent comment too by one of the attendees. I just want to add that all too often it seems people with disabilities are being left out as a marginalized population with unique lived experiences and some of the highest rates of adverse child experiences and traumatic experiences. We talk a lot justifiably about the effects of race and ethnicity, but disabilities are consistently left by the wayside. Thank you for that comment. Okay, thank you so much for that wonderful presentation. I'm gonna, let's see, we are, I think, at another break. Yes, that is correct. So we have 10 minutes, so please come back and reassemble at 3:20 for our excellent panel.